So what exactly causes pain in osteoarthritis? So I'm going to use the example here of the knee because that's perhaps one of the most common joints affected by osteoarthritis. And before I dive straight into the nooks and crannies, I think it's worth just reviewing very briefly the anatomy. So from the top, the superior side, we have the femur. The femur has two rather large knobbly bits. These articulate at the end, at the distal end. These articulate with the tibia, the shin bone. Just on the outside of the shin bone, just lateral to the shin bone, is what we refer to as the fibula. Now, the joint, the true knee joint, which is encapsulated by the actual knee capsule, comprises purely of the tibia and the femur, not so much the fibula. Arthritis is confined largely to the articulation between the femur and the tibia, and we're going to, for the sake of this video, dismiss the fibula. Now, on the articulating surfaces, i.e. the distal end of the femur and the proximal end of the tibia, the thigh bone and the shin bone, where these two articulate, you have got a little bit of a covering on them. And that covering is cartilage. This is what we refer to as hyaline cartilage. Hyaline cartilage essentially is very smooth and it covers those bony ends. In the context of osteoarthritis, what we have wear and tear of that cartilage. It's important also to appreciate that between the tibia and the femur, i.e. the shin bone and the thigh bone respectively, there are two structures. On each knee we've got two structures known as the menisci, singular meniscus, what we refer to as the medial and the lateral meniscus. The menisci are actually held down on the tibial plateau, on the top of the shin itself, by little ligaments referred to as coronary ligaments of the knee. Now, in the context of arthritic change, we also get wearing, or what I personally refer to as fraying, of these menisci, which are made up of fibrocartilaginous material for the most part of, similar to the material of the pinna of your ear. Now, going back to the actual hyaline cartilage, the covering, the cartilage that actually covers the bone, as that wears away, what happens is the bone underneath it becomes exposed. And the exposure of that bone is what starts to actually cause the pain. So that layer of the bone is the more superficial layer, what we refer to as a periosteum. And the periosteum is extremely highly innervated, which means that there are lots and lots and lots of nerve endings that actually are found in this periosteal layer. And when we remove the hyaline cartilage that covers the periosteum, the exposure of those nerve endings is what then stimulates nociception, i.e. pain perception. The analogy I use here is that of the crown on the tooth. Now, thankfully I've never experienced this, but those of them who have are very well accustomed to the level of sensitivity and pain that occurs or arises as a result of removal of the crown on the tooth, exposure of the enamel, and the level of sensitivity of the enamel is evident because the said patients will complain of pain, serious pain, even on slightly warm or slightly colder fluids. So the point here being the periosteal layer or the periosteum that's exposed has got the nerve endings that we speak of, which cause nociception. And it's the reason why, in the context of osteoarthritic change, we experience significant pain. Now, there are various treatments to try to manage this pain, and conservative measures first. I think a point to also consider here is that inside the capsule, where you find the distal end of the femur and the proximal end of the tibia and the menisci, we've also got some fluid, what we refer to as synovial fluid. And there has been vast amounts of research around medications or vitamins that may promote the regeneration of the synovial fluid, as well as regeneration of the actual hyaline cartilage. Your glucosamine sulfate and your chondroitin are the most largely researched, and there has been some literature published and verified that certain doses of glucosamine sulfate may actually stimulate the reproduction of synovial fluid, but there's literature around chondroitin is still limited and still undergoing significant research, unfortunately. The synovial fluid is what the joint articulation actually bathes in. In the context of osteoarthritis, there is also a reduction of that here. And so when we consider and the likes of conservative measures may include exercise to try to re-establish the strength in the muscles of the thigh, the front of the thigh being the quadriceps, those behind the thigh being the hamstrings, and those on the actual lower, in the lower leg, i.e. below the knee. You've got the calf muscles, the gastrocs and the soleus, as well as those on the front of the shin to some degree. But the larger muscle groups, the hamstrings, quads, and the gastrocs region, or the calf muscles, are the ones that we need to work on, because exercise stimulates the collagen that's deposited in and around the tendons to be of greater structural integrity than that which is already there in the context of osteoarthritis. So therefore exercise does help. The movement of those joints through those exercises also stimulate to some degree or another the production of synovial fluid, i.e. the lubricant that is, and so that again will enable reduction of some pain and management. And then you have the heat. For me personally, I suggest heat most around the back of the knee, because heat stimulates vasodilation, i.e. opening up of blood vessels, and therefore promotes blood flow, and it promotes an increase in hemodynamics in the locality, therefore driving out some of the inflammatory mediators, including prostaglandins, which may cause the nociception. And finally, then you can go down the lines of pharmacological interventions, such as your analgesics and your anti-inflammatories, as long as there are no contraindications to the said. And your anti-inflammatories work in a slightly different way to your opiates, for example, in that the anti-inflammatories will actually clear out some of the inflammatory mediators that are responsible for the nociception, once again, including the likes of your prostaglandins, amongst others. So various drug regimes, various pharmacological interventions, and even a regime there is perhaps something to explore after the conservative measures, and as long as there are no contraindications to the same. So there you have it, osteoarthritis, and why it is that you actually feel the pain. What exactly is it that causes the pain? Thank you for watching.